Hi, good morning, good afternoon, everyone, and welcome. On behalf of the Pan American Health Organization, and specifically the Evidence and Intelligence for Action in Health Department, and the Digital Health Information System for Health, IS4H, I would like to warmly thank you for joining us today. This webinar is part of the Digital Literacy Program and the Certified Webinar Series, which aims to strengthen regional capacities in digital health, civil registration, vital statistics, interoperability, health information systems, and data governance across the Americas. And before we begin, just a few housekeeping notes. Today's presentation itself will be delivered in Spanish, but we do have simultaneous interpretation available in English, Spanish, Portuguese, and French. Please select your preferred language using the interpretation icon on the bottom of your Zoom screen. And we encourage participants to use the question and answer function throughout the webinar to submit questions and comments. We will try to address as many questions as possible during the discussion period at the end and during the webinar. And this session is being recorded, and recording and presentation materials will be shared afterwards with the participants. Today's webinar addresses a very important topic of the region, the transition from ICD-10 to ICD-11, not only as a change in classification systems, but as a part of the broader digital transformation of health systems and strengthening the interoperability between clinical systems, civil registration, vital statistics, and information systems and health ecosystems. The webinar will explore how the ICD can function as a common semantic language across clinical care, mortality, civil registration, statistics, and public health decision-making, and why this transition is important for improving data quality, comparability, and reuse across institutions and countries. It is now my pleasure to introduce today's presenter, Dr. Víctor Hugo Álvarez, a consultant with the PAHO, who has extensive experience supporting the countries in the Americas on ICD-11 implementation, mortality coding, CRVS strengthening, interoperability, and digital health transformation initiatives. Víctor Hugo, thank you very much for being with us today, and the floor is yours. Thank you.
Muchas gracias, Katri. Entonces, voy a compartir
Thank you,
pantalla.
Kadri. I'm going to share screen now. Do let me know if you see it.
Ante todo, muchas
Okay,
gracias
so first of all, thanks a lot, all of you and the organization, for this opportunity to share with you some reflections about the most important key elements we need to consider for the transition between ICD-10 to ICD-11 in the region, although it applies to the whole world. The point I'm going to focus on, it has to do with ICD as a source to interoperation of data of mobility between the vital statistics and healthcare information systems, most particularly understanding that ICDs as a common language enables for the meaning of clinical findings in the diagnosis and causes of death can be preserved throughout the whole chain, although it circulates among different institutions and platforms. And that's the key point of this presentation. As it's been mentioned, we're going to be working in several results, amongst them the differentiations between technical and semantic interoperation to make it a common standard. We're going to see some use cases, and we're going to try and identify what are those key points we need to work to implement a transition toward its 11th version. So I want to focus on this specific part. That is when we talk about the transition between ICD-10 to ICD-11, that oftentimes is understood as us being in a process of code updating, which is going from a version of one form of coding to a more current one. And here's where we're going to see it in a different way, because in reality, it's a lot more than a change of codes. It's a change of data languages. And what does it mean then? Or what do we mean by saying a data language? We mean a group of rules, commands, and syntaxes that allows us to exchange and interact with databases managements for those that are interested in ICD-11. A data language in a system can help give structure and to modify. It helps manage various information systems, charts, indexes, etc. But a data language is also the one that allows users to be able to manage information, so they can inquire, they can insert information, they can add, or they can delete data from their system. So ICD-11 allows clinical data in diagnosis and causes of death to be dynamic, moving through the various records and toward the various components of healthcare information systems back and forth without losing significance. And that's the great input of ICD-11, because as a standard, it preserves and it helps preserve the meaning of those terms and the various platforms and institutions. Now, what do we want to be able to address? What's the actual problem we mean to fix? And why do we need to move it toward ICD-11? Well, basically, that's because we have a series of elements. We know that in the practice, data does move around, but they end up losing, and on their way, they end up losing significance or changing significance. And these are the frequent abnormalities that information systems have. One of them is that the use of free text, acronyms, modernisms, or new words that are not known may apply. Something very frequent as well that it tends to happen is among the pains that affect information systems is the use of local catalogs that are not a match. So it's very frequent with the users of the ICD-10 that are now using several versions that they have downloaded from official and not official sites, which ends up having a big effect when we want to analyze data for aggregations because they're not comparable. So this will imply a lot of rework also for the clinical setting, for coders, for those that work with registration and statistics. So it's something that has been seen a lot, and it's one of the issues that underlie in the information systems. And with that, we're going to miss the opportunity and the traceability of data, because then corrections arrive late or they happen in some other inflow or outflow when it's not timely at that point. And so that's why we say that interoperability interoperation is not just the exchange of messages, because two systems can communicate pretty good and receive the same file, but they may produce different interpretations. And that is when we find the most important issue, because it's not so much data circulation. Data transfer or exchange occurs very frequently, but not necessarily under the terms that we want, with a full interoperability that can guarantee the preservation of the initial meaning of that data throughout its journey. And that's where ICD-11 finds its most value, because it helps us correct when used as a common language and not just as an information catalog. So, the foundation of this reflection is that ICD shouldn't be seen as a new catalog in its 11th version, but as a semantic standard that is implemented as a process. Because what does that mean, to be implemented as a process? It means that as a common language, ICD-11 is given a consistent guidance to documentation, coding, the reuse of data for different effects. So, with that in mind, it can help the clinical diagnosis and causes of death treated with a specific semantic standard can keep its meaning and circulate with the same significance through institutions and the various platforms, thus generating data that is useful to be reused, and to guarantee with that the comparability and traceability of information. So ICD-11 does not replace data governance and processing. That's something that we need to keep very clear, but it does certainly enable that circulating among different actors, it can preserve the same meaning. So it doesn't replace it, but it actually works as an engine, not only in the process of digital transformation, but also in the management of information, making all the governance and processes incorporated into the data flow to be manageable. So what changes from ICD-10 to ICD-11? And with this, I want to summarize a little of that change. That change is not only about classification. There's also a change on the way we use it, because ICD-10 showed a logic of use to be traditional, and it was and still is something quite consolidated in terms of being considered like that by institutions and within them, but it does not have the capability to integrate natively with digital process of today. So it has a lot of limitations. In fact, the use of ICD does not go beyond, in the best of cases, to being used as catalogs or reference lists and information systems. And so that is also subject to local adaptations, where they make a difference in the series of information. While ICD-11 was born with mostly a digital approach to facilitate its integration into all digital workflows, with the giving support to various tools of search and coding, providing better support for data reuse in several moments. This then facilitates the permanent use of information and the systematic use of information, which is not happening with all any opportunity that it had with the ICD-10. So the implication of this specific change toward ICD-11, it implies an improvement of its interoperability potential, which we very much need in information systems in order to keep comparability and the good data reuse in a more efficient way. Now, where does it fit ICD-11 in this scenario, particularly in that dynamic between civil registration, vital statistics, and healthcare information systems? Well, throughout the whole chain, it shows the real value of ICD when used systematically throughout the information flow. And so not only at the end to be able to generate reports, but the journey begins from the very clinical care. It starts from the clinical care, going through certification and registry, coding, consolidation, analysis, and its use for decision making. For each of these points of contact, there's a loss of significance. And that's where ICD-11 as a semantic layer can guarantee or standardize the significance on each of these critical points as information flow. So allowing coherence on the information among institutions and platforms. And so this is specifically critical, particularly for civil registration and vital statistics systems, when these are flows that can guarantee the movement between this and other actors. And so for healthcare information systems, having such diversity and components within the healthcare information systems, you need governance, you need an architecture, standards, and capacities for data to be useful. Okay, so we have to make a differentiation here. Talking about the interoperability that we are, that gathers us here in the ICD-11, and that has to do with the technical and semantic interoperability. So what that means is, so technical or syntax interoperability is all that cluster of rules that allows us to send a message, to receive files, and have an application respond to us. So the systems are able to exchange messaging, but that's not sufficient for data to be useful for decision making. For that, we need to have a complement in the semantic interoperability. So that's the one that allows us that when the data travels through, it can keep the same significance. This is the standard that can guarantee that there is no loss of information due to any change in significance, and that all actors are understanding the same thing, all stakeholders. So that's the value of ICD-11 as a semantic standard that works as a layer of common significance in the information systems. When we do not have a semantic share that is shared, the result is that we're going to have inconsistent results, less comparability, ambiguity in the data that may distort any decision made based on them. So the difference that is very important here between these two kinds of interoperabilities that are intrinsic to the use and application of ICD-11 are very important and must go shoulder to shoulder. How is then all this we're talking about of the common language going to be operated? How does ICD-11 become an institutional value? So it doesn't work as a document, but as active processes. And we are working with interoperative mechanisms where the first one is the structured capture. When you define critical fields, controlled lists, validations, and these validations need to be on time. This is going to help with a data capture that is not going to show as much ambiguity from the very origin of that data, and hence it's going to be a lot more efficient. And the second mechanism of coding and application of codes and rules through its definitions can guarantee consistency between texts and codes, and it allows for decisions to show traceability, and they will naturally reduce the workload afterwards when we don't have to reprocess data. And then finally, a third mechanism to transform ICD into an institutional value lies in its analytic reuse. When it starts from the very origin in a structured way, that data is then validated into its consistency, then we can say that we can use it in surveillance for data management and quality management as statistic for decision making. And in that sense, it's not only then enough with changing the catalog, but to redesign the whole workflow. And it's not then as simple to run this transition process if we look at it in that way. We shouldn't look at it in a simplistic way. Let's look at a case of use. Let's talk about mobility. And so what's happening? There is a clinical a chart that could be recorded in this example. So we have a patient with diabetes type 2 with nephropathy, hypertension, and insufficient control. This clinical summary is quite clear, but the problem shows up when we are about to record this clinical summary in the various systems. So there can be a place where we find these as a complicated diabetes type 2, or one with kidney damage, or a diabetic nephropathy, or we may even lose the important contents of the clinical remarks and then have only a partial coding. So that means that the same case could be represented differently in the various institutions by the different stakeholders. What are the implications then for that? Well, that it's going to be very difficult for us to be able to cluster, to count, to reuse the data. And then when we have a disruption in this comparability, then that is, in fact, the current situation that is forcing us, or that it makes it justifiable to use the common language of ICD-11. Because the current situation is that the data is traveling, but the significance is not guaranteed all throughout. So what happens when we use the common language for the management of information in terms of mobility? Okay, so let's use the same case under the use of the common language with a diagnosis that could be labeled in a better way, because in the process with ICD-11 using a common language, we could capture that information from origin in a more reliable and comprehensive manner and in a very structured manner. And also because you can gather all the features and clinically relevant elements to be able to describe properly a clinical condition with a lot less ambiguity, because the ICD-11 allows to fully describe clinical concepts when clearly documented, of course, and the combination of terms that can add details to that diagnosis so it can be a lot more comprehensive. So ICD-11 as a semantic standard provides that consistency. It gives you that possibility for traceability to know who, when, and how the information was generated and documented. And its institutional use is a lot more optimum. It can be used for all cohorts to provide configuration to cohorts quality management, but particularly for clinical management, which is very important in the clinical setting. And that is that the diagnoses that are documented under CD-11 have a better value due all of its contents for the patient's clinical management. So the gain of incorporating ICD-11 in mobility processes does not lie in being able to code more, but in coding better, and to have data to be reusable without having to constantly be translating such data. It reduces terminology variation, it increases comparability among institutions as well. Okay, let's see. Let's take a look at a second case of use. In this case, mortality. In mortality, the data goes through a value chain that is as important as the very certificate. It starts with a medical certificate with the record of a causal sequence, and it's a content that goes through coding, and then it's integrated into civil registration and vital statistics. It's consolidated, it's subject to analysis, and it is then the source that feeds decisions in public health. The critical point of this flow and mortality is the interoperability, which in this case is intersectorial. It is very sensitive because these are several different stakeholders, healthcare, civil registration, and vital statistics that need to read the same significance. Otherwise, if they're not interpreting that data in the same way, if they interpret something different, then the system will lose its coherence. And the thing is that the small errors made from the very origin with the incomplete causal sequence and mortality with a term that is improperly defined or incomplete data, it's just going to amplify at the end, and it's going to cause discrepancy, tasks that were repetitive, loss of traceability, and a whole workload of reprocessing and delays. So it is critical and to have a good application of ICD and mortality within the full workflow. So I'm being very emphatical here with the term of coding and the use of ICD-11, that it's not just as a code to make final reports, but it's part of the whole process from the very origin of data. There are some critical points in the quality of mortality data, some points where it may degrade itself, and there are 4 specific ones where the first one has to do with the cause sequence, because order and clinical coherence also determines the basic cause, or if there is any ambiguity, or if it's not specific. So this may be the most critical issue in the quality of death certificates, for instance. Another critical point is the mandatory fields that are not filled out, and the causes that are not registered, and that does not allow the basic cause. So it's the completeness that implies reprocesses, like a requirement of an amendment or a review that causes delays. And another critical issue is legibility and the standardization. The use of terms that aren't easy to read or acronyms that are not understandable can cause mismatching between the certificate and the coding. These acronyms, in addition to other errors that may have to do with data being readable, all this implies an institutional rework, and that is another critical point, because that doesn't come by itself. This bring or can generate extra costs for entities looking for a typo that needs to be corrected for the proper use and stuff like that. So you miss a lot of opportunities in there with such critical points. So the strategic question at this point is, where do these losses appear? Where are they generated? And so we have to look into the whole information chain, from the certification by the physician, its registration and coding or statistics, where these losses come up, to be able to correct them and to control them. If there is no control of those losses, then the impact is going to bring in a specific causes, distorted trends, delays, and more workload. Talking about manual work in terms of the transformation of useful data for the decision making. And to finish this case of use related to mortality specifically, we're going to compare then the before and after. Before, without digital support, the most frequent findings were in specific terms, causal sequences that were incomplete or incoherent, missing fields, coding that shows to be affected by high variability, a rework, a delay in the consolidation of data, its publication, and possibilities of use. While with ICD-11 combined, and when I say combined, means ICD combined with a digital process of all that data workflow, then that's where we're going to find a gain, particularly in data quality and the ability to create this data without losing its significance throughout its journey. So with captured digital systems, it is important to think of it, because it helps certifiers to fill out the document in a better way with all the information needed because it brings them alerts, but also gives coders a support because a validated text that has been done so prior by the certifying agent is the best evidence to run the whole coding process, thus providing a lot better opportunities and traceability in the registration. It is always important to remember that the use of ICD-11 it's not a separate entity from the processes of registry digitalization. It's the very nature of ICD-11. So this needs to be perfectly in sync. And so this is a call for the countries that are going through these processes of digitalization, that this isn't something separate from the integration or implementation of ICD-11. They should go hand by hand using ICD-11 as the golden standard. Now we go into the part of keys, the keys for transition, where the first one and most important maybe is governance and the cases of use that we're going to prioritize to make that implementation process better. It is important for this transition to be led as a data schedule and not just as a coding project. This is very important to keep in mind because this is what I had said earlier, that it allows to move on into a synchronized process of data management with quality. So the first thing we need to change is we need to change the narrative. If we introduce the transition of ICD-11 as a change in codification, it's going to be reduced to a technical peripheral different kind of task, which will be pertaining to coders and statistic groups. But when we present it as a change in the data language, then we understand that we're talking about enabling interoperability and quality management throughout the system. So we need to understand ICD as that opportunity, as that tool that allows us to move on in the processes of digital transformation of our healthcare information systems. But it demands that change in narrative. Okay, it is also important to prioritize the cases of use within that schedule because we can't just start applying ICD-11 for all topics at once. We have to be capable to go little by little. You cannot implement the whole thing. You have to select the cases of use, maybe those that are the most critical first, those that have a high value, so that we can learn through pilot tests on how to use it, how to incorporate it, how to integrate ICD-11 within those processes of information systems in health and civil registration and vital statistics as well. The third thing is to define governance. We need to define who owns the standard. And so it's very important for that. And I have to guide your attention toward the entities that need to exercise the management. What we were saying before, varied catalogs, that are not comparable come to be oftentimes because there isn't a proper management in the countries to be able to guide what are the rules, the versions, what are the changes, what's the version that needs to be used to guarantee unity in the information, to guarantee as well the continuity from the statistics standpoint. So governance is that one main element, and it needs to be documented with guides and precise instructions, and with champions that are the ones that are given the track and the line to be followed.
Bueno, pero hay otro punto que no podemos omitir dentro de la
But there's something
transición
else we can't ignore within that transition, which is data continuity, the statistic continuity of data. And that's because we're taking the risk when we're going from ICD-10 to ICD-11 to find changes that may not have to do to the changes of classification rules. And they may not be real changes. So we have to be aware and stay alert and keep monitoring them, because that is a gap that is showing typically in transition processes that has to do with the protection of data series. It is a concern, so we have to guarantee comparability and preserve that confidence throughout the whole transition that data is representing the reality. That is why it is always suggested to have a coexistence plan between ICD-10 and ICD-11 throughout the whole transition process. That they need to have a good baseline with ICD-10 and recent reports, while introducing at the same time or defining what's going to be coded in ICD-11, from when, what setting is that going to be applied on. And this must always be subject to constant testing with pilot trials for each application of ICD-11 according to the case of use that it needs to be used for. So this is needed to be able to forecast what the impact of that change in coding will have, and to be able to compare it with the current needs, and to define where are those comparison factors or those rules of comparison that need to be considered to train according to the findings that are recorded. And once a moment is reached during the transition period to have a stable series, then a good result will be to leave some rules of coding and authorization to all users for data management, with methods that are clear, instructions, mapping, etc., in such a way that the procedure and its use are standard. And of course, a continuous monitoring needs to be put in place to validate consistency and data quality.
Bueno, clave
a second very important key is the one that sets the transition process, facing the question of what happens if we lose our way in terms of processes and capacities. So it is necessary to think about the components of processes, check them adjust them, make changes in workflows if needed, and creating enabling capacity building. Capacities that aren't only going to focus on technological infrastructure or a system of a quality management, but also in the human talent, skillfulness, trying to identify what is the different roles and how do they work together within a process of transition towards ICD-11. So it's necessary to be able to identify those roles and define what is each one doing. For physicians, it is very important, for instance, to focus on clinical documentation and causal sequences and the more specificity of data that is being recorded. For coders, they need to be in full domain of rules that can guarantee consistency, quality control. Those are the ones that supply information for such follow-up. For information technology professionals and those in charge of interoperability, they need systems to be able to interact with one another through integration with updated catalogs and precise information in these catalogs with constant variations. And then those that are responsible of these data, the managers, because the information managers need to use this data for continuous improvement. So it is very important to consider this second key. They have a strategy that is a differential strategy to train a human talent, because one of the most important errors that are found is when there's the same kind of training for all roles, when each one requires the specific knowledge and tools according to their role within the system. A third element that is key is what makes that transition plan measurable and manageable. So it's not about a document only, where you're going to insert what the pathway is, but this needs to be operated through a quality system that begins on the very first day, and it needs to be established with a few indicators that are clear and doable. So it's not about having an X number of metrics, but that the few indicators that we do have can be workable, meaning that each indicator, as long as measured, can generate an action. So minimum indicators recommended for a transition plan are these here, where we find the completeness of critical fields, the consistency between the text and code, the opportunity of that record versus coding, the review and audit to measure how frequent it is, what does it come up, what are those discrepancies by service or institution. So those are the indicators that need to be generated or designed in a doable way, as I said, so that it can work as the dashboard that can trigger corrective actions, training activities, etc. So you need to start with a very simple dashboard, but that dashboard needs to allow me the monitoring of this process. And then finally, some take-home messages, maybe to wrap up. What I want for you is that you can take with you these 3 specific points for your transition plans to think about your processes from ICD-10 to ICD-11. And that is what has been said before about the narrative, to be able to see ICD-11 as a common semantic language that can allow me to guarantee the same meaning all throughout actors, stakeholders, platforms, all throughout the data workflow of health information. Also, that you must not see it just as a catalog. The other message I would want you to take home with you is that transition is a social technical process. So it's not only the change of a catalog. It is a process that implies having and establishing governance, defining processes or redefine them, update them, integrating them, to have proper platforms and the development of these basic skills that we need for this transition and adoption process. And then finally, the pathway toward transition needs to always be done by phases, always prioritizing cases of use and always running tests to validate the results. A minimum pathway that is established is the 24 months one, but obviously many countries will need a lot more time. And within this time, it's not likely that we can do it. Maybe in one institution, but for the first months, you're going to need to establish clear rules for governance and to select the cases of use and then work with pilot testing. And simultaneously, and during that time, understanding that it can take a whole 1 year, you need to provide training by roles and to establish a quality system. Then on a second or even third year, we could think in the progressive scaling up for a whole country. Okay, so this is an example of a roadmap where basically we are gathering that in a transition plan, various phases need to be considered to make the process of transition realistic, to move from ICD-10 to ICD-11. And it starts with the first readiness phase, where the institutionality is being prepared, where the rules of the game are being defined for that governance to move on in the process. Then we go to a phase of capacity building that is going to demand a lot of effort, a lot of work for friends. I'm showing 5 lines here, which is what the WHO has told us in its guide, where structure and governance are not just an administrative act or the creating of a team, but it's maintenance and to actually exercise that governance throughout the whole transition and after. Training of human talent, adequacy of technological infrastructure to guarantee data comparability with data management systems, and also a promotion and advocacy of ICD-11, so that then this can be something that all stakeholders involved can own it. This is followed by a phase of project implementation and pilots. Everything needs to be tested. And then it ends with a consolidation to the change of ICD-11 when everything is structured and scaled up at a national level. We must remember that each phase is going to bring deliverables with champions of each area, and that it also brings costs. That's why we can't just ignore the thought of the funding of these activities involved in a transition plan, and that is key to be able to succeed in that transition process toward ICD-11. And as a final idea, here, going from ICD-10 to ICD-11, it implies to adopt a common language. So in this sort of summary, of the activities that we have been talking about in this kind of decalogue, to go from codes to a data language, to change the narrative, to understand the concept, mature that concept, and being able to express it, to start with cases of use that are priority, to consider governance very carefully, to always make sure that the semantic interoperability is within all the updating, the digital updating of the system, to redesign the capture its very origin, that cannot go separate ways, as we had said before, to strengthen coding with rules, with traceability, to always be assessing what is the consistency between texts and codes, training by roles, a differential training that is not only tackling what kind of strategy, to strengthen the quality system from the very first day with key indicators, to always protect the whole process all throughout the coding process, and the coexistence and strategy of the transition and the escalation by phases. Okay, so this ends my presentation. Thank you all very much for your attention, and space is open for your questions. Katri, go ahead.
Gracias, Víctor Hugo. Yo voy a cambiar en español ahora.
Thank you, Victor Hugo. I'm now going to go with Spanish. There are 3 questions in Spanish. And the first one is about if there are if there's a criteria for the construction of these indicators, like a minimum criteria. The second question is about the data and to keep the ICD-10 in parallel, because there are several versions of ICD-10 in the country. So how to keep that part on the data a country can handle from ICD-10, talking about the years 2008, and the various versions in time. And then the last question comes from is saying if the country has lost its capability, install capability of coders, and it is fundamental to work then with coders for the ICD-11. Okay, about the first question, yes, there's a certain criteria to be able to define what are those minimum key indicators that should be present for the management system. So first of all, they need to be simple. They need to be measurable. They need to be clear and well-defined. And they need to also have its thresholds defined. So what is it I am measuring? And when will the indicator tell me that there is a change and improvement or a lack of improvement thereof, and a delay of a process that we are measuring? And something else that is key is for that indicator to have to be linked to a specific action.
supongamos que sea
So let's say that the
la
indicator
proporción de
is
certificados
the ratio of
diligenciados,
certificates that are fully
certificados de defunción
filled
con
out. We're talking about death certificates
completas, con
with full
información
sequence in their
idónea para
information, and that information is suitable for all
calidad del dato y de codificación.
data quality
Si
and
esto
coding
tiene,
processes.
uno
If
espera un 100%, ¿sí? Pero
if it does, then you would expect 100%, but you can establish a threshold of at least 90%,
debajo del cual yo
below
que,
of which you
desencadenar una
would
acción
have to
concreta
find that a
de
specific
revisión,
action
de
comes up that
capacitación,
triggers
revisión de
review,
las
training,
variaciones de
the review
los
of
datos desde el origen,
variations
etcétera.
of
Entonces,
data from the very origin,
el
etc.
estándar o los criterios son
So the
estos, que
standard or criteria
bien
is actually
definidos
that
los estándares,
that the standards
los
need to be very
indicadores,
well defined, that indicators
que
need to be
sean
very
medibles
specific, and that they
positivamente,
need to be objectively
que tengan
measured.
umbrales para
They need
tomar
to
las
have
decisiones y que
thresholds
tengan
for
una
decision
acción
making, and they need to
ligada a ese
have
indicador.
an action
En
linked to
relación
it.
con la segunda pregunta,
About the second
sí,
question,
hay gran diversidad de
yes, there's a
versionamientos del
large
ICD-10
diversity
en la
um,
región, ¿sí? Porque
of
en
linking
aquellos donde
information to
existe alguna
ICD-10 in the
rectoría, pues
region,
digamos que
and those
el
where there's
estándar es
management
uniforme,
of it,
¿sí?
then
En
the
la
standard
mayoría de las
is
veces.
equal most times.
En otros, pues,
In others,
cada usuario
each
ha
user
recurrido
has
a las descargas en el sitio donde
used the tools of downloading them from websites that they think are
y por eso hay esa
easier, maybe
diversidad de
because
versiones.
out of
Digamos, aquí, pues,
ignorance. That's why there's
yo
a
creo que
whole
no hay que
diversity of
entrar, digamos,
versions.
como en
And in this
conflicto.
part,
Lo
I
ideal
wouldn't go
sería
into
que
conflicting the reasons, but
país
what's
que
ideal
tiene
is that a
proceso de
country
transición,
with
que
undergoing a
va por un
transition
proceso de
process or
transición,
going
pues,
through a transition
establezca
process
cuál
needs
es
to
esa
establish
versión
what
última
is going to
actualizada del
be that
ICD-10
ultimate updated
que
version of
está
ICD-10
aplicándose
that
en el
they
país. Si hay una
will apply
diversidad,
into their
pues
country.
es
And if there
diferente,
is a
pero
diversity,
hay distintas formas
there may be
con las
many
pruebas
ways
pilotos que
with pilot
podría
testing that could
hacerse
help
ese
them
análisis y mirar
analyze
cuáles
to
son los
decide
factores de comparabilidad
what are going to
que
be the
permiten,
comparison
digamos,
factors that
el
can
uso de
allow
distintas versiones.
that country for the
Allí
use of
es un
various
desafío
versions.
el que plantea
And it's a challenge
Amanda, ¿sí?
what Amanda
Porque
brings up,
pues
because
el incentivo que
the
hace la
incentive
OMS es
the
a que
WHO offers
durante el
on
periodo
that
de
is that
transición
through
se
that
mantenga
transition period,
la doble codificación, pero
the double
no
coding can
retroceder,
still
digamos,
be there, but
en
never
los
going
procesos
back
que ya están
in the
implementados, sino
processes
que
that are already
ahora que
implemented,
ajustarse a esa
but rather
versión
to adjust
que
and
está siendo
adhere
utilizada,
to
porque
the
sería un
newest
retroceso
version being
que
used,
puede
because
no generar,
otherwise it
digamos,
would
mayores
mean a
beneficios.
reprocessing
Entonces,
that
esas son
could
situaciones
generate,
para analizar muy bien
could
antes
come in
de
detriment
emprender,
instead of being
digamos,
beneficial.
un
So
estudio
then this
comparativo.
needs to be understood
El tercero
first
no
before going into a
recuerdo,
comparison
Carmen, si me lo repites.
work. I don't
La
remember
otra
if there
pregunta
was a
era
third question.
pérdidas
Yeah, the
de
third
códigos
one
canales en el
was
país en
about the
contexto
loss of
recién
coders
usted.
in the country in the context of
Bueno,
ICD-11.
bueno, yo creo que el mensaje es que
I think that the
necesitamos
message
clarificar
here
más
is that we
todavía,
need
pero ojalá
coders
puedes
still,
clarificar un
but maybe you
poco
can
cómo
clarify a
se va a
little
manejar
on
casos de
how
mortalidad y morbilidad,
the
porque
mortality and
son
morbidity
diferentes
information is going to
codificadores
be handled, because
en ambos.
apparently there are
Gracias.
different coders
Sí.
in both.
Bueno, pues recientemente
Yes, well,
México pudimos
recently
ver
in Mexico, we were able to see
las herramientas que ha producido la OMS, que
that the
está
tools
produciendo y sigue
that WHO is
actualizando,
providing, and they're
pues son un
constantly
recurso
updating
muy
them,
valioso
are a
para
very valuable resource
orientar, digamos, estos procesos. En
in guiding
mortalidad,
these processes.
yo diría, la mayoría
In
tienen procesos
mortality, I'd say that
centralizados,
most
¿sí?
have
Y
rather
en ese
centralized
sentido
processes.
es una ventaja
And
porque
so That's rather an advantage because the tools that have been created facilitates the use of ICD-11 and the quality improvement with various applications. For instance, in the case of those such countries that have centralized coding, then the work is actually simple because it uses a limited group that you're constantly training, strengthening, giving tools to so they can run the process. Now, what's behind it is that going back to the very concept I have addressed in this webinar is that we need to see the ICD-11 not as a catalog, but as a common language that needs to be considered as such from the very beginning of the information chain. So the challenge is not so much in the application or use of ICD-11, but the processes that improve data quality. And it is undeniable that coders are the main stakeholders, and they're always going to be needed. We're always going to need the human intervention to validate, to supervise, to review all coding processes, both in morbidity and mortality. So that's part of the management considered within transition plans and that need to be incorporated when there are no coders. Wherever we have coders, even if they are dispersed within the institutionality, we need to capture them and give them the tools to replicate it within their institutions and multiply as well. Okay, I think there are no more questions. And I'm going to now speak English to finish the meeting, to close the meeting. We have taken 10 more minutes and we don't have a lot more time for simultaneous interpretation. So thank you, Víctor Hugo.
Dr. Hugo, for excellent presentation, and many thanks to all participants for joining us today. We hope that today's session provided useful, practical, and strategic perspective for the countries working on ICD implementation and digital transformation initiatives. And I would like to take the opportunity also to highlight that the World Health Statistics Report was published yesterday by the WHO, and its focus is on the CRVS systems in this year. We have Chile as a country highlighted as one of the case studies, and it's the report demonstrate a critical role of quality of mortality and population data for public health. And we also would encourage everybody to subscribe to Community Practice mailing list to continue exchanges, experiences, and tools and lessons learned. And we would like to also to remind and invite you to the next webinar in PAHO Digital Literature Program certified webinar series, which will take place on June 11th, 11 a.m. and Eastern Time. And the topic is good practices for digital identity. And please read the scan the QR code on the screen for registration and additional information. Víctor, ¿puedes compartir la lámina con código de QR? And thank you again for participation and continued collaboration with the PAHO, and we hope to see you again in upcoming sessions. Have a good day, everyone. Thank you.